Right, good afternoon everyone and welcome to this meeting of the Health and Wellbeing Board, the first one under the new Labour administration. So what I'm going to ask everybody to do first is introduce themselves, because we've got new members of the council here, which is very welcome, and older members who perhaps haven't been on the Health and Wellbeing Board before. So I'll start. My name's Teresa Murray. I'm Deputy Leader of the Council and the Portfolio Holder for Health and Adult Services.
Good afternoon.
Thank you. Catriona, John.
Hi, I'm Matthew Capper. There we go, how's that? I'm Matt Capper, I'm the Director of Strategy and Partnerships at Medway Foundation Trust, and I'm here on behalf of Jane Black, who unfortunately can't be here today.
Good afternoon, I'm Phil Thorne. I'm the Community Engagement Lead for Healthwatch Medway, and I'm here covering for myself.
It's especially nice to see Healthwatch here. Thank you for coming.
Thank you.
Good afternoon, everyone. My name is Mike Gilbert. I'm the Executive Director for Corporate Governance at NHS Kent and Medway. I'm here on behalf of Paul Bentley, who is the Chief Executive of NHS Kent and Medway.
I'm David Whiting, Deputy Director of Public Health. I'm not a voting member of the Health and Wellbeing Board. I'm here for the session later on.
Hello, my name is Sue Irving. I'm the Head of Adults Partnership Commissioning and Lead for the Better Care Fund for Medway Council and the ICB, and I'm just bringing a paper today.
Hello everybody, I'm Stephanie Davis. I'm Democratic Services Officer and Clerk to the committee.
Afternoon everyone, I'm James Williams. I'm Director of Public Health and Lead Officer for the Health and Wellbeing Board.
Hello everyone, I'm Tracy Coombs. I'm the ward member for Watling and the Education Portfolio Holder, and I'm a member of the Health and Wellbeing Board.
Hello everyone, my name is Marian Nestrov. I'm ward member for Watling and I'm also Deputy Mayor.
Marion saying he's also the Deputy Mayor and he's substituting for one of the Labour members today. Thank you for coming.
Hello, I'm Councillor Eddie Peake. I'm substituting for Councillor Stamp, Ward Member for Wayfield and Weeswood.
Good afternoon, Councillor Gary Hackwell. I'm a Ward Member for Rainham South East.
I'm Councillor Zoe Van Dyke, Portfolio Holder for Business Matters, and I'm substituting for one of my colleagues today.
Substituting for Councillor Price, I think,
okay,
today. Yeah, thank you. So, thank you, everybody. Just before we start the meeting, I wanted to say a few words. We're very pleased to have the Health and Wellbeing Board and for all of the commitment, actually, that all of the partners have shown to the Health and Wellbeing Board since its inception. I want it to be as collegiate and partnership-based as possible. I do remind members here that it's not a scrutiny meeting, it's a partnership meeting where we're wanting to drive the objectives for improving the health of everybody in Medway. And I want to make sure that everybody is respectful to all of the different roles that the partners hold around doing that. We can be critical friends to one another, but I hope that we've all got the same objectives in mind. That is to tackle health inequality in Medway, make sure that people live long and well here and lead happy, fulfilling lives. And this board has got a big part to play in actually making that happen. So, yeah, do you want to?
So thank you everybody. So before we to formally start the meeting, we do need to nominate and appoint a Vice-Chairperson and a Chairperson. So can I please have a nomination for a Chairperson, please?
Can I nominate Teresa Murray?
Okay. Can I have a seconder, please?
Can I second that?
Thank you very much. So, Councillor Murray, I can confirm that you have been nominated and you will be the chairperson for the municipal year. Now, can I please have a nomination for a vice-chairperson, please?
I nominate Jane Black.
Can I have a seconder, please?
I'll second that. Yeah.
Thank you. I can now confirm that Jane Black has been is the vice-chairperson for this municipal year. Over to you, Councillor Murray.
Thank you. And just for everyone's information, Jane Black is the Chief Executive of Medway Maritime Hospital. Okay, so that's, in the spirit of this being a partnership board. Thank you. So I'm going to read all of the apologies for absence now, and thank you to the substitutes as before. So Councillor Adam Price, Leanne Farrakal, Director of People, Children and Adult Services, Martin Riley, who's the Joint Senior Responsibility Officer for Medway and Swale Integrated Care Partnership, Jackie Brown, who's our Assistant Director for Adult Social Care, Andrew Stradling, who's the Interim Medical Director at Medway and Swale Care Partnership, Health and Care Partnership, and Paul Bentley, who is our Chief Executive of the Integrated Care Board. And someone's apologised for you, Mike, but you're here. So that's a good thing. And for invited attendees, we've got apologies for Adrian Richardson, who's the Director of Partnerships and Transformation at KMPT. And someone's apologised for you, Catriona, but it's nice that you're here as well. So I'm very happy about that.
I have one more apology, which is Donna.
Oh, yes, and Donna Marriott, who's our Assistant Director of Social Care, Children's Social Care, is unable to attend today. But we'll make sure, obviously, that all of those people who would normally be on the board hear about the things that we talk about today. Okay. Right, I'm now going to the record of the meeting, and I think lots of people at the meeting on the 13th of April, those meetings were not published with the agenda in error, and they'll be published for approval at the next meeting of the board. So if that's okay with everybody. And I think that most of the people here probably weren't at that meeting anyway, but we'll make sure that the actions are taken forward. So thank you. Item 6, can I ask if there are any urgent matters? I don't have any. Okay, thank you. Item 6, declarations of disclosable pecuniary interests and other significant interests, please. Are there any declarations of disclosable pecuniary interests? Thank you. Are there any other significant interests? Zoe?
I'm not quite sure whether I do. I was a governor of the Medway NHS Foundation Trust. I did resign, but I appear to still be recorded as being a governor, so just in case.
Thanks, we'll make sure that's there. Matt?
No, nothing from me.
Nothing from you, sorry, I think you had your hand up. Did anybody?
Councillor Hadley.
Sorry.
Just like Zoe, my wife is also a governor of Medway
Okay,
Hospital,
thank you,
just for
Councillor Hadley.
interest.
Thank you. And any other interests at all? Okay, thank you. That's the end of that item. I'm going to go on to the main business. Going to go on to the main business of the meeting now, which is the Better Care Fund, and I'm very happy to pass Sue Irving to say a few words by way of introduction. But before she does, can I point out to everybody, and particularly for the new members, the Better Care Fund is about the extra money that comes from government to help us manage social care. A huge amount of work has to go into actually proving that we can get the money, such that is, and as things stand at the moment, not quite enough, but welcome anyway. Huge amount of work has to go into filling out all the government's criteria to show that we're doing everything that they want us to do in order to get the Better Care money. And I do thank Sue and her team and everybody who contributed to that, because we'll see the paper today, but there's a huge amount of work that's gone on behind it. And I want to place on record my thanks to all the partners in the voluntary sector, because obviously they work with us to deliver some of the things that we hope the Better Care Fund can deliver.
Thank you, Councillor. Chair. So, thank you, Board. I just wanted to just remind you all that, or introduce the fact that the Better Care Fund policy framework for 23-25, confirming the conditions and funding, was published on the 5th of April. That didn't give us an awful lot of time to get things done, but we did, and the plan was submitted on the 28th of June. We now wait for the assurance. The plan was introduced in the idea of the Better Care Fund was introduced in 2015, and it's utilised to support people to live healthy, independent and dignified lives through joining up health, social care and housing services. The BCF achieves this by requiring integrated care boards and local government to agree a joint plan, which is owned by this board and then governed by an agreement under Section 75 of the National Health Act of 2026. It's governed by a group called the Joint Commissioning Management Group, which is our senior officers both across the ICB and the Council. The delivery of this new plan, the requirements of this new plan are two new objectives, which is to enable people to stay well, safe and independent at home for longer, and to provide people with the right care at the right place and at the right time. And the BCF programme, which is delivered from the BCF plan, it's all jointly coordinated and agreed. There isn't a single organisation that decides this is what we're going to do. Everything, it is a good example how we integrate between health and social care. The plan that the Councillor very kindly made kind comments about is jointly created by the Medway and Swale Health and Care Partnership, the ICB Central Management, Joint Commissioning Management Group, as I stated before, oversees the plan's development as well as the plan's implementation. And the delivery of the plan will include those partners and operational officers at the VCS, housing officers and care providers. So I ask the Health and Wellbeing Board to consider the plan and then note it, please.
Thank you very much, Sue. And you can see at 2.4 all of the things that the plan covers. So I'm going to open up for comments now.
One of the things that I found interesting was the technology that's going to be helping to look after particularly older people who have falls. Could you tell me a little bit more about how we make sure that these older people are able to engage with the technology and how that will help them to kind of have better care?
Thank you, Councillor. There's lots of work that goes on falls, and in fact, the Better Care Fund this year will be focused more on fall technology. We have a certain element of the plan money, but also ICB money, that looks towards pieces of equipment that help people from the first responders to get people off the floor. So if an ambulance goes to a person's home that's had a fall, they use this equipment, and care homes do as well. So there's equipment that is basic enough to just lift people off the ground. Then there's I was going to say technical equipment, that's the wrong word, tech equipment that people can use, like lifelines, but also sensors within their homes to see how they're moving, that they're eating, etc. Then there's so much. There is so much that is done and is being looked to be done, but those are two examples. We also use technology within the care homes as well.
If I can just add something to what Sue said, Tracy, because that's a really good question that you've asked. And assistive technology is incredibly important because it can keep people more independent for longer. And there's more than one element to it, aren't there, Sue? So part of it is the kind of equipment that people can check their own health, so that the data from what they're checking, it might be hypertension, blood pressure, it could be blood sugar, it might be heart monitor, lung function. They can upload the data from that to those involved in their care, and then the people involved in the care are able to make an intervention if that's necessary when assistive technology is working really well. And one of the things that there are bigger pilots, I think it's fair to say, than we've done here in Medway yet, where people find that not only does it help them to feel secure and comfortable about their own health, but they feel comfortable with working with that technology as opposed to always having someone coming to the house. And obviously, it does help save resources within the healthcare community because it means that people are having to do less visits. And I think, as a wider point, I've seen that we really need to do some more training for our own social care staff in the use of new assistive technology. And I'm very pleased to say that the university have agreed to let us in outside of term time use the flat that they've got there that's used for paramedic training to rig up with assistive technology, and then we can take some of our staff there and let them see it in action. Because one of the things that social workers can do is to recommend assistive technology as part of a funded care package. And very often that doesn't happen, and I think that's because people don't feel so confident themselves as a practitioner with recommending the assistive technology. So looking forward to that, and also looking forward to working with the social care team to put on some other training with assistive technology providers so people can see what's out there. Because good as those lifelines are, and they're the pendants that people wear that they can press if they're in distress, they've been around for about 40 years. Things have moved on, and for some people who've got those, they're paying for them, or we are, and actually they're not using them anymore. So there's a bit of work to be done, but I think it's a really exciting development, and I'm glad that you asked the question, Trish.
So just related to that, Chair, and as you've alluded to, I think the other difference is, the lifelines, people press those after they've had an incident. The whole idea about lung function, blood pressure testing and everything else, and this is being piloted and increased. We were told earlier this week that the pilot in terms of care homes is being increased in terms of how it's rolled out across the whole of Kent, across Kent and Medway, is that it allows in advance of somebody having a fall to forewarn care professionals that there is an additional potential of somebody falling, and therefore to consider whether they intervene in advance of somebody falling, which is really important. So it's actually trying to stop the fall in the first place, or the issue in the first place, rather than responding quickly to the incident after it's happened.
Thank you, Mike, and that's welcome news, I think. James? Oh, do you want to go first?
Yeah, thank you, Chair. There's a couple of things I'm not sure you'll be able to answer. On page 27 or 13 of the report, depending on which page number you're looking at, I just want to know why Platters Farm is not going to be sooner than October 24, which seems an awful long way off before we can reconfigure it. And I wonder if anybody's got an updated figure of the patients waiting, because that figure that's quoted in the plan is over a year old, of 32,000. So I'd just like to get a feel of what's happened in the last year. Thank you.
Sorry, Councillor, I didn't get the first question.
The first question is about Platters Farm, reconfiguring beds for dementia, and it says October 24. I just wonder why it's taking so long.
No, it's done.
It's done.
We had those. We had to have those. We had to put that date in because Platters Farm Lodge is. Some of those beds are utilised within the Intermediate Care and Reablement Service, and that was part of our commissioning discussions, because we've just finished tendering that service, so we couldn't give any more information until we'd had that conversation, but it has been reconfigured now. Yes, they're operational. I didn't get your second question, sorry.
The second question was on the patient numbers. In the next paragraph, it said a year ago we had 32,000 patients waiting for treatment. I just wondered if anybody's got an update on what that number is now a year later.
Yes, we'll have those data, so we have to report on the plan every quarter. So we'll and there are some metrics that are listed in the plan on those data, so we'll have up-to-date information as we go through the year. But when we create the plan, it has to be used the assured data, so from a year's data. So we'll have data as we go forward this year.
Two questions from me, both around elderly care. One of them is about the incident, a question about what the incidence is of elderly patients admitted to hospital who are then catheterised when they arrive at the hospitals, and I've seen this in hospitals outside of Medway, is quite prolific. So my question is that a practice that is carried out, and what the incidence of that is you want to deal with that question first and the last?
I wouldn't have that information.
Okay.
This paper was specifically about the plan, so I wouldn't have that detailed health information, but I can try and get some for you.
Thank you. Sue James is going to answer that.
Excellent. Sorry, James.
Oh, it works. So the operational detail, and it is really important. I was going to come back to the false stuff. It's just to give members assurance. This is our overall plan. That's an interagency, interorganisational plan for us to set out the priorities that we're going to use the resources for and to collaborate on. The actual detail, members will get updates. And of course, when you look at the cycle in our work plan, because this is the role of the board, you've identified a really important issue about quality and also some practice. But when we come to that particular issue, we will get more detail and we'll be able to do more of a deeper dive. Come back to Councillor Hackwell's comments as well about waiting lists and things like that. That kind of detail is normally quite operational. It's the grit that we need to have. But as a board, what we then do is we say, what is it that we can do to actually support the colleagues, the organisation, to improve that particular issue. So it probably would just be we can come back to those issues and perhaps go into a theme we've got colleagues from our NHS here. We might then say what we're doing about quality, what we're doing about, you mentioned that particular intervention, and they would be able to bring forward information to give us some insight.
Okay. Would anyone else like to comment for Zoe on that use of catheterisation for elderly patients?
I'd love to, but unfortunately I would probably give you the duff numbers. We can absolutely, outside of this, get you numbers of what that looks like at the moment. I would say that obviously these are clinical decisions, so they're based on clinical evidence and what's presented at the time. There isn't a one-size-fits-all policy for catheterisation, so it is depending on clinical need and things like that. But we can absolutely look at that, and as James said, it will be part of the broader conversation as we move through this.
Yeah, my concern is that it's happened due to service pressures rather than a clinical need in the instance that I've observed.
So if I might, Chair, there is, just for assurance, a quality group that sits across the whole of our system, and we've got 2 tiers, one led by the medical director for Kent Medway, then each area has got their own sort of quality group, and things like that you're describing around the practice, that's what I'm sort of alluding to there. Those things are identified, and what then happens is this quality group looks at that, and if there are issues, as you've described, where things potentially are being done that are outliers or shouldn't be getting done, then those kind of things will get picked up and brought forward in that clinical spaces, as Matt's already said. But there is a group, just for assurance, that looks at those specifics. I did, Chair, if I might, I wanted to just touch on the falls data, because as we've heard already, the assistive technology is really important. Wearable devices, we all know, I mean, most of them have got smartwatches on now, and they've got accelerometers in them, and that's pretty much around some of the technology that leads into whether people are that way or that way and whatever else, and it's really quite good, that speed. But I just want to go back to some basic things that we can all sort of do and share. So things around hydration, and particularly for older people. And I think Catriona would probably suggest, because we know that people with cognitive impairment, they might not be able to manage those issues when the heat's on and what's what. Some of the basic messages, postural stability, everyone understand what that is, strength-based work, so reaffirming the roles of prevention to help to reduce the likelihood of people falling is really important, alongside those other devices and tools that we've actually got. And so what I'm saying there is we've got a whole suite of things, and it's the benefit of mixing them all and matching them and making sure that we've got the appropriate tools available to support that individual and whoever it is that's wrapped around that person, particularly in the context of falls, because they're quite devastating, and we know the impact, not least on social care for people who go forward, have a fragility fracture, particularly a fracture of the hip, and then they end up, unfortunately, if they're not able to go home, in our care, social care, and that, if we can avoid it, which we can, we need to just put that emphasis. So just want to bring us back to some of the basic stuff, as well as the wearable devices, which are quite snazzy, but practical stuff might also be assistive for us.
I think, if I can just, Tracy, I think we missed a point that you made, which was, can people actually use it, and do they know what they're doing? And Tracy's absolutely right to ask that question. When I visited carers groups particularly, there's no reluctance on the part of people to use it, but that they haven't been shown how to. And people around the table might have heard me say before, we've got to stop pretending that everyone who's got a smartphone can do everything that someone else who's got a higher spec smartphone and is a much more experienced user is able to do. And one of the things the carers groups that I visited in during Carers Week said, was that they would like to be able to attend a learning session that wasn't a formal class, because some of them had already done that and everyone was at a different level, but actually a drop-in session where there was somebody there who could deal with them particularly and the particular things that they wanted to learn and think about using. And actually, quite frankly, James and I have discussed this, that includes things like using a blood pressure monitor and a lung function monitor and being able to read it. So I think there's some joint work that we can do with partners and with our own adult education service in trying to put some of those sessions on. So that's something that I really want us to focus on and think about the capacity we've got in all of our organisations to help towards that, including with the universities, where there, may be medical students, there may be other students who are studying technology who might be able to help with that and kind of help to engender that sort of intergenerational approach to making it the norm. So that, as far as I'm concerned, Trace, that was a really important question that you asked, because so much technology is talked about, and it makes people who don't feel that they can use it confidently then start feeling left out and isolated from that particular discussion. And I think, Phil, that there's something here for Health Watch to pick up on, isn't there? Whether people that you're working with feel confident about assistive technology. And definitely, I think the point that Zoe made about catheterization, if it is happening sometimes because of pressure of work, then that's having the kind of reverse impact on a person who might be catheterized with their continence and with the way that they're feeling when, that their needs could be managed in a gentler, less invasive way. And I think sometimes when we've got particularly elderly relatives who go into hospital, that's a big worry and a big shock for families when they find that has happened.
It is, Chair, and in terms of data we actually hear from the people of Medway anyway, I can't give any definite information as to what we've actually been given, whether anyone's actually raised any concerns. But the whole purpose of going forward into the next year, particularly with my role, is actually getting out and speaking to more groups that we aren't hearing from about this. Health Watch's parent organisation, EK360, is already part of something called Hypertension Heroes, which actually goes out right across the county. I believe we're already doing some work in Gillingham. It's a separate thing, but again, I can link James you up with Eve de Grey Bircher, you may know already, who's kind of coordinating that.
Thanks, Phil. Listen, you've touched on a point, so I might as well answer it. So it started here as a pilot in Medway, and we've got because I've just got the data actually, which I was going to share as an ALB, but through you, Chair, if I might. So we are now the second highest we were performing area in the southeast for our hypertension checks. So one of the things that we want to, through our Hypertension Heroes programme, is to get to those communities who are less likely to come forward. And we've been showcased at a national level. We had the Deputy CMO come down to look at that particular project. And that is one way in which we are reaching in, as Councillor Murray's already said, to some of those communities that need that support. But actually it's the tools. So when we're talking about that sort of health literacy, people being able to use gadgets or whatever else, we did do through one of my annual public health reports, which is why Councillor Murray's just linking back to that. But there is more that we need to do. And I'm pretty sure that we've got a solid basis, but in order then to meet the needs of those people who aren't actually accessing some of these tools, who are new into our community, who aren't aware of all the support that may be available, we do need to keep on top of it and promote more. But yeah, I'm pretty pleased that the numbers are 80% cumulative uptake from 2018-19. So that shows it's over a 5-year period. It's pretty positive.
Thank you, Catriona.
Thank you. I had a query about... No, yes, about wearables and the requirement for internet access, because we know there's a significant deprivation divide across Medway in relation to having that digital access. So I guess it's, are we factoring in potentially the cost of providing the internet access to support the use of certain wearables and technology? And I also had a question about whether the digital strategy will tackle, be a bit more ambitious about artificial intelligence, as well as perhaps the more standard equipment that has been available for some time.
To that. I mean, that's a really key question, and I should have mentioned that when I was talking about making assistive technology part of a care package. I think we have to face the fact that sometimes getting people connected to the internet is going to have to form part of that cost, and we've got to look at it in the round, because for many people, they probably haven't got a connection anyway, and, you know, health workers will turn up with a dongle and be able to access the internet, but actually when they go home, the person that they've been working with hasn't got access. So I think that has to be definitely part of the picture, and I'll leave the second part of your question to James.
Thanks, Chair. So you need to read my annual public health report if you haven't already read it. So it sort of goes into that and answers some of those questions. So what we've been doing is providing devices that are internet enabled to people, and we've got a giveaway scheme as opposed to a let scheme, and that's been part and parcel of some work where we got some funding, and we've been working with Adult Ed and also like Mid-Kent College. So we've been working with people to give them the skills, but also then giving them the tools. The digital access bit, and that was one point, and the chair's been really clear about that. As an enabler, as an organisation, Medway Council clearly has been responsible for putting in, you know, the super fast broadband stuff, and that's why, you know, you've seen holes in roads and things around the place. But part and parcel of that, we've got a digital strategy which is 100% about enabling people to be able to access the internet wherever it is that they're at. So the two things there. One, we're providing the equipment, so people who can't afford to have it have got access to it, and of course that's the context of it. But we're not in isolation. The NHS as well have been rolling this out as part of a broader scheme around digitalisation, and that's why we've been trying to work in partnership. So we've got an overall strategy for that, but it's a great point that you make. But clearly we need to make sure that people, through evaluation, are seeing the benefits, and that's an ongoing piece.
I think, Catriona, there's a piece of work, did you want to come back to? Yeah, there's a piece of work to be done about whether people actually know about it in the first place, so that they can, you know, anticipate what's going to happen. And I include there organisations like Extra Care, setups, residential homes themselves, or, you know, domiciliary home care companies that are working with us. I think, you know, we can talk the talk, and we can talk about amongst ourselves as a group of, you know, elected members and professionals, but the extent to which everybody who needs to know is in the lap a bit. And I think we've got to, you know, work together to improve our communication to give people that confidence.
You answered what I was going to say.
Telepathy, everything works, that's good. Any more questions or comments? Zoe, yep.
Just a question about elderly residential care capacity, particularly with increasing incidents of dementia. How fit for purpose is it?
Well, I think if our AD, Jackie Brown, was here, she'd say that we need to do more. I think that we all recognise it's a national issue around finding the appropriate type of support and care that people need in late years. Some of that might be care facility, but, you know, we have got some distinct challenges around the workforce being able to, you know, be in place to support people in that particular area. And you know, I will pass to Sue, but it's a live issue. It's one that is a challenge for us. I know that members, and particularly Cabinet, are looking at different alternatives as to how we can provide that capability that we do need, but it's not just about the buildings. There's a whole workforce piece there that we need to look at that bridges the gap, and Sue might want to touch on some of that.
Thank you. Part of my role is to commission social care, so the care homes and that. We work with all our care providers to make sure that their workforce is fit for purpose. And as James alluded to, the care homes and the nursing homes are really struggling with workforce issues at the moment. It isn't necessarily that we haven't got enough beds, it's that we haven't got enough staff. And what we're doing there is working with our NHS partners to give assurance that the status of a care worker is just as important as a nurse, and that is a very much a joint thing. COVID hasn't been good to us in many ways, but it has brought our two organisations together, and health and social care work very well. But to give assurance, as James has said, we are looking to a wider and longer term picture, but currently my officers and I look through planning applications and talk to developers to create new care homes, but we also look at asking care providers to extend their homes, to extend what their offer are. We look to support those homes if they look like they're getting into trouble. And I don't mean that financially, I mean with officer support. So there is lots of things we do on a daily basis to support our care sector. It is an activity we focus on daily. Does that answer your question?
It's helpful. Helpful, thank you, yes.
Yeah, and just to add to that, Zoe, you're absolutely right to ask the question. We can't hide behind that either. There's 150,000 vacancies, and we've got to play our part in professionalising care work and making those who work in care feel, first of all, that there's a career to have. Secondly, that they get paid more, and that, I'm afraid, is on the table the whole time. Most care workers are earning the minimum wage. And if they're in the domiciliary sector, they don't get their travel paid. If they're in the residential or support sector, it's a similar sort of situation. And unless and until we create those opportunities, I'm afraid we're going to continue to have those vacancies. And we're looking to NHS partners, because I think we have to create pathways going both ways, don't we? That there may be people who are working in the NHS who would like to change in the later part of their career, perhaps, to a more flexible arrangement, which, after all, domiciliary care particularly is quite a flexible way of working, and vice versa, that people in social care can feel that there is a pathway into the NHS for them if that's what they choose to take. And we've got to be honest about the disparity of pay and conditions between them, I think, and that, that we won't be able to see those vacancies diminish very much until we do that. On the positive side, we're working with the newly formed Kent and Medway Health and Social Care Academy so that we encourage people into care in a very positive way, because one of the things is that our local college, they've got plenty of people on care courses, but they don't, when they come out, always end up going into care or hardly end up going into care. So we've got an issue of an ageing workforce as well. And we've got to, that's why making care an attractive thing and looking at where care workers who are coming into the area, as well as NHS workers, can live affordably. That's something else. And I was very pleased, actually, at the Health and Wellbeing Strategy Refresh meeting that we had recently. Catherine from Planning here, came along and showed, in a very pressured workforce, as they are at the moment, trying to get a local plan in place. She committed to spending that morning with us so she could hear from all of the practitioners the needs and help to write that in to the local plan. And once it's written into the local plan, that's when we'll start to see changes, I think. I think that brings us to the end of what... Oh, Eddie, yes.
Yeah, so I was just wondering, sorry, it's such a basic question. How aware are we of all the companies that provide care? So, I used to be a care worker, so I'm talking from experience, and the company I worked for changed hands, I think about 3 times within the 5 years that I was there. Horrendous turnover of staff. Nobody ever felt appreciated for the work they do. Are we confident that we know all these are private companies, basically, and they claim to have charitable status, but that's just a lot of, I can't think of how to say it politely. They're private companies there to make as much money as possible. Are they all bought into what we're trying to do here? Are they on board? Do we know all of them, who they are? Sorry, it's clumsy.
Again, Sue will pick it up, but the context is around, as an organisation, and as partners, we want to ensure that the people that we work with are able to deliver the outcomes for the people that we serve. And so we'll be quite, we won't know everybody. I'm pretty sure if you've got a new person that comes into the market, we might not know them, but we do have a quality assurance process for anyone that goes through to deliver our services, and that's quite robust, I would suggest. I'll pass to Sue. Yeah, but I accept your point. What I would say is that we won't know every single person that comes out that's providing care, and bearing in mind the way in which that can be done now, if somebody's got, you know, their own sort of personal budget, they can engage with somebody and get them. We wouldn't know that. I mean, that's pretty low level, but that person could also then be working for other people. I'm not sure that we would have that detail, but Sue will give you a bit more of an overview about the process that we use to ensure that we've got some understanding.
Thank you, James. So, Councillor, what we have is we have a commission service. So that means those care, whatever service it is, be it care home or be it domiciliary care, home care, they have to tender for it. They'll have to go through a process, and they have to be CQC registered. And we would know of all the care providers, even if they're not part of our contracted, we would know that because they're on the CQC register. So if we ever hear from a resident that's using them and they complain about them, because any resident can complain to the council about the care they're receiving, even if it's just care that they provide, they pay for it themselves. And we say that, well, they approach them first, then the CQC, because the CQC will inspect those people. If they're a commissioned service, we monitor and we manage the contract, so we know our providers and we know if they've got a high turnover of workforce, we ask why, as it alludes to the question that I mentioned about workforce earlier. We've much more got our finger on the pulse than we did pre-COVID. We know what we had to, because it was so low, and we've built it up. So yes, we do know where most of the care homes are, most of our care agencies are. They have to be CQC registered to be able to deliver care, whether we work with them or not.
Yeah. It's Mike.
So just to add to that and to follow on from what James was saying about personal health budgets as well, with personal health budgets, there is an element of, well, in fact, there's more than an element. We do also check to make sure that the people that are providing care that we're paying for as part of personal health budget. So if somebody wants to bring in their own carer or their own, somebody to look after them in terms of particular areas, where that relates to healthcare, then we don't, it's not like the CQC inspection regime, but we do satisfy ourselves that that's appropriate care for the money that we're paying and for the funds that we're paying. So there's an element of that. I think where we don't have so much, and we've got a fantastic voluntary sector in Medway and in terms of the organisation that sort of coordinates that, but I wonder whether or not we pick up all of the voluntary sector elements of private organisations that then add on the add-on services, which would be really difficult to do that. But I know that there is a substantial list of the voluntary sector organisations within Medway though that we use.
Eddie, you're coming back.
Yeah. So I'm talking from personal experience again. How far do you look, or what is your remit when you look at the provision of care? So the company I worked for was CQC. So in some ways my question was silly, because obviously you're going to know, because obviously Medway came and inspected us. So one thing is the actual direct care for people, quite often personal care and so on. But arguably also the practical side. So I remember working for a company where quite often there was no washing machine facility. You need to use probably all day long washing machine, wasting money, having to go out to laundries. Quite often an oven that didn't work. You couldn't prepare quality food. Bathrooms that leaked. I mean, the quality of the premises was disgusting. And this obviously had effect on us as a staff. Where you've got a manager talking to us about standards, and you look around and go, you're taking the mickey, aren't you? I mean, how much do you get involved into that type of thing?
Come back on that, Mike. Yeah.
Thanks. So what I think I'm hearing is it's really an important point for us, particularly as a board. Are we assured that, the outcomes that whoever it is, and in your case, you've got direct experience of carers working, and then whether the regulators or the people that are commissioning those organisations are getting a true picture of what is actually happening. So what we have got within the system, and this sits within the Integrated Care Partnership, but we've got a representative for all of the care organisations across Kent and Medway who sits on that particular committee, and it may well be, rather than us trying to unpick this issue now, that we look forward and say, can we get that person in to give us an overview as to how, because they represent all of these organisations, and that might be a better debate for us to have as a board to give us assurance around those processes. So that'd be my steer, Chair, if we do that.
Yeah, I think well, if we can add that, Stephanie, I'm sure that you will. Because it's a really important point that you make, Eddie, and I think, you know, people's lived experience isn't always the same as whatever the CQC or even our own reports are telling us, and it's incredibly important to be mindful of that. Well, I think thank you for sharing those experiences, and I can understand, you know, how staff feel when there's that disconnect. Was a really useful debate. So we're going to move on now to agree that we note that report and take forward some of the comments. And I think there's a couple of actions that have come out of that. And on your point, Councillor Hackwell, about Platters Farm, obviously that's on your patch there or thereabouts, isn't it? So I think it would be nice, Sue and Stephanie, if we thought about offering a visit to certainly council members there now that the work has been done, and probably to the members of health scrutiny as well. Yeah, so I'm moving that we note the report, and I need someone to second it because we haven't got the Vice Chair here today. So Tracy's saying that she seconds that. Thank you.
Just on that visit, can they be open to members like me that's not on the committees?
Yes.
Yeah?
Yeah, I mean, if it's a lot of people that want to go, they couldn't all go at once. But certainly, if we can take that as an action and have a look at it, I think that would be helpful to people. Because when I was on health scrutiny, I remember that was something that we were intending to do and never got round to. Okay, and we're going on to the work programme. So that's over to you, Stephanie.
I don't actually have anything to add, but I'm happy to take any questions.
We did say that we'd have a mental health item, didn't we?
We have a mental health item at
thank
the
you.
September meeting.
Thank you, Chair. Thank you, Stephanie. So I actually spoke that because there's one of the items on the report that is an update on GP development plan, but the date is yet to be confirmed. So I spoke with Suk Singh, who is our Director of Primary Care Services, to say what would be best for that. The board has an option, I suppose. The primary care team can come back in November, which is I think it's the next meeting, or is it can come back in the meeting after next in November, where it can update on the development plan to date and talk about how the new primary care strategy, and particularly those areas also outside of GP services, so pharmacy, optometry and dentistry, which we know is all an issue, is going to play going forwards. Or if it leaves it till February, that primary care strategy will have been signed off, and therefore they'll be able to come and sign the primary care strategy. So he's happy to do either. He's happy to come in November or February.
Yeah, I think Steph's saying what would I prefer, and I think we would like to have an update, Mike. It would be really important, especially from the point of view of everybody in Medway who's concerned about GP services. And I think some of that work is going to dovetail with our own GP task group work. Suk and Logan are taking that forward, aren't they? And so at that point, I think that would be great. And then obviously come back in February when it's signed off and see how we've got.
One other item for addition to this is obviously the Foundation Trust's clinical strategy, which I think would be really helpful to bring here. It will, a large part of that clinical strategy actually is taking what we would normally do, which is quite internal facing, actually showing you how we're starting to look broader, certainly in the remit of this this body as well. So if it's okay with you, I'll work with Stephanie to see what the best appropriate date is for us to table that here as well. So.
Anyone else? Oh, yes, Catriona. Thank you, Councillor Hackwell.
Just a query on the Medway Mental Health Services update expected in September. Is that adult mental health services or children and young people's services as well?
At the moment, I believe it's just adults. It's been Vincent Badu is leading on this at the moment. We do have a meeting next week to discuss it in detail. So if you wanted to add anything to that, Katrina, just let me know.
And just for you, Katrina, it might be worth catching up with the Medway Adult Safeguarding Board, because we had a huge item at the executive recently, and as much as anything, it was that motivated me to say that I think the Health and Wellbeing Board ought to have a look at it. And I think for your organisation, you have had lots of changes, some of them that you shared with us at the refresh strategy, but it would be nice actually to hear about the way that you think they're working, particularly as you link with the hospital as well. Yeah. And we've got an update on places of safety, haven't we? And the new attitude that the police seem, a little bit unfortunately in my view, to be taking towards their attendance at mental health crises. So I think if we can just, bring those things together, it would be helpful.
We are looking at some point as well in the cycle to take children's mental health and CAMS as well. It's just trying to decide on a date for that.
So if there's nothing else to add, subject to the things that we've put on today, I'm going to propose that we accept the work programme, and I need a seconder for that as well, please. James is seconding that, so that's fine. And I think that's it, everybody. We said we'd finish at 3 because we've got the development session, and for someone who talks as much as I do, I'm very pleased to say that we've managed to finish before time. So I hope everyone will have a cup of tea and a small snack, and we'll see you back in the room. Do we want this layout, David, or do we want...